Good evening, everyone. My name is Nistara Singh Chawla. I'm a PhD scholar from Department of Physiotherapy, Manipal College of Health Professions, Mahe Manipal. And today I'm going to discuss with you the ADHERE trial by Amreen Mahmood et al. Stroke is one of the leading causes of disability worldwide, and its burden is even more so in low and middle income countries, and it is increasing with time. Therefore, exercise are an integral part of physical rehabilitation after stroke. Home-based exercise programs are essential for post-stroke rehabilitation. However, adherence to these programs is often noted to not be optimal, which impacts their recovery process. Initial researchers have indicated that only about 28% of stroke survivors adhere to the prescribed home exercise programs, which highlights the need for effective strategies to enhance adherence to exercises. The study objectives were to evaluate the effectiveness of specific adherence strategies in improving compliance with home exercise programs among stroke survivors in semi-urban India. Additionally, the study assessed the effects of these interventions on mobility and quality of life. There were two research questions which were addressed. So, for people with stroke compared to usual care, does addition of personalized strategies to support home-based exercise increase the proportion of participants who adhere to prescribed home exercise program? Does it also improve the level of adherence to home-based exercises, leading to a greater improvement in their mobility or quality of life? And what factors influence the level of adherence to home-based exercise? It came out to be 51. Additionally, the participants were not blinded to the study group. However, the person measuring the outcome measures, the investigator, was blinded. So this was a single blinded study. And these strategies were designed to enhance motivation and compliance. So the strategies were delivered to these patients in 5 different sessions. Session 1 included education, exercise prescription, involvement of the family, and cognitive remediation. Session 2 involved education, exercise prescription, involvement of the family, cognitive remediation, along with motivational strategies. Along with that, in session 3, that is, or on the which was delivered on the day of discharge, feedback and supervision was given, exercise prescription was given, cognitive remediation, self efficiency, involvement of the family was done, and motivational strategies were given. Session 4 was done at 1 week after discharge, which was for a telephonic follow up, and prescribed strategies were reinforced. Session 5 was done at 2 weeks after discharge, which involved feedback with supervision, family involvement, cognitive remediation, self efficiency, involvement of the society, motivational strategies, and reminder strategies. So these strategies basically focused on personalized goal setting, motivational interviews, regular follow-up calls, and educational sessions. Outcome measures were taken at 3 different stages. Primary outcome measure was stroke specific measure of adherence to home based exercises, that is SS MAHE, which was done at 6 and 12 weeks. Secondary outcome measure was mobility, which was evaluated using mobility disability scale, and for quality of life, stroke impact scale. Data collection was done at baseline, 6 weeks, and 12 weeks. Coming on to the results. A total of 127 participants were screened for eligibility. 58 participants meeting the inclusion criteria were randomly allocated to the experimental and control group, with 29 participants in each group. So at week 6, what was observed that experimental group demonstrated significantly higher level of adherence compared to control group, with a mean difference of 45. And at 12 weeks, it was a sustained improvement in adherence observed in experimental group with a mean difference of 51. As for the mobility and quality of life, again for mobility at 12 weeks, participants in experimental group exhibited better mobility outcomes with a median score of 42 compared to control group with a median score of 95. For quality of life, however, no significant differences were noted between the two groups, both at week 6 and at week 12. So, coming on to the discussion, what were the implications of the study? So, this demonstrated that implementing structured adherence strategies significantly enhances compliance with home-based exercise program among stroke survivors. Also, improved adherence correlates with better mobility outcomes, underscoring the importance of it in integrating it into standard rehabilitation protocols. Quality of life considerations. So, despite adherence and mobility improvements, there was no observed enhanced quality of life. So, this suggests that physical capabilities may advance, but other factors such as emotional well being, social support, and economical challenges also influence quality of life, and they also have to be considered while evaluating quality of life in people with. The success of adherence strategies is, in this context, highlights the necessity of culturally tailored interventions. So, understanding local beliefs, socioeconomic constraints, and healthcare access is vital to designing an effective rehabilitation programs, especially in context of low to middle income countries. The limitations of the study are that it was a relatively small sample size and the geographical area is limited to a semi urban area in India, which may affect the generalizability of the result. Additionally, intervention was limited to 12 weeks. So, a longer term intervention may lead to better results, or we do not know actually what are the outcomes that could be seen at a longer term. Future further studies should explore long term sustainability of adherence strategies and the impact of diverse populations across these regions. Investigating the integration of technology such as mobile health applications could offer innovative solutions to enhance adherence and monitor the progress. So, coming on to the conclusion, this study demonstrated that tailored adherence strategies are effective in improving both adherence to home based exercises and mobility outcomes. However, they did not yield proper significant improvements in quality of life within the 12-week time frame. So, the take home message from this is that healthcare providers in low and middle income countries should consider incorporating structured intervention into home based stroke rehabilitation programs to enhance patient outcomes.